So I don't know if you guys can hear me okay. When I switch to
Yeah, we
the
can hear you.
presentation, can you hear me?
Yeah.
Okay. All right, so I'm going to present on an ICU patient that I worked with for several weeks. I'm going to call him Michael White. He is a 36-year-old male, and he presented to the emergency room with complaints of severe abdominal pain, cramps, and vomiting, and he was diagnosed with a small bowel obstruction. So he was actually treated with just medical management in the emergency room, like IVs, bowel rest, NPO, not eating anything by mouth. And he actually refused an NG tube and he was discharged home. So he returned to the emergency department after about 12 hours of discharge because his symptoms got far worse and he was taken to the OR for an emergency exploratory laparotomy. When he was in surgery, he actually aspirated the stomach contents into his lung and left him very critically sick. So just some key terms we talked about there was the small bowel obstruction is a partial or complete blockage of the small intestines. NPO means nothing by mouth, and this is a safety precaution because the stomach contents fill into your lungs during anesthesia if you aspirate. The NG tube is a nasogastric tube, and that enters through your nose and carries either medicine or food to the stomach, and it can also suck excess fluid out of the stomach. An exploratory laparotomy is a general term for an extensive surgery where the abdomen is open. So in this case, the surgeon unblocked the area of his intestines, repaired and removed the damaged section of his intestines. And then we talked about acute intraoperative pulmonary aspiration, where there's entry of liquid or solid material into the trachea and lungs. So that being said, he was left with some serious post-op complications, and he was placed on a mechanical ventilator and ECMO, which we'll talk about in a little bit, at the site of his right femoral artery. He was sedated, he was medically paralyzed for several days, and 2 weeks after his surgery, he ended up with a tracheostomy and a PEG tube. He also developed compartment syndrome of his right lower extremity, and he had to have an emergency fasciotomy with a wound vac placed. So some of the key terms there, the mechanical ventilator, it's a machine that takes over the work of breathing for the patient. So that was through an endotracheal tube, which went through his mouth. The tracheostomy is a surgical opening at the front of the neck to allow the tube insertion into the trachea to help the patient to breathe. A PEG tube is a feeding tube, so that goes in through the stomach. It's actually through the skin of the stomach wall. And compartment syndrome is when pressure builds up in and around the muscles, the nerves, and the blood vessels, and the pressure becomes so extreme that it limits the flow of blood and oxygen to the muscles and nerves. And this is pretty bad because it can cause permanent damage to the muscles, and it can be fatal, or you could, lose your limb. That happens at. So the fasciotomy is the surgery that they used to treat the compartment syndrome, and that's when the surgeon cuts the fascia and it just relieves the pressure in the limb, and it's done to save his leg essentially. And then the wound vac is the wound vacuum assisted closure of the wound, so that can help to heal where the fasciotomy site was. So here's a picture of what ECMO looks like. ECMO is when blood is pumped outside of your body to this big machine. It's a heart-lung machine, and it removes carbon dioxide and sends oxygen-filled blood back to the tissues into the body. So the blood flows from the right side of the heart to the membrane oxygenator machine, and the heart-lung machine is rewarmed and it's sent back to the body. And this just allows the heart and lungs to rest. It basically bypasses those organs. So it's a pretty serious line that the patient has, and you have to be extremely careful. It wasn't very common that we would mobilize people with these lines, but our ICU was pretty progressive, and they did have us work with patients on ECMO. The ICU that I work at now, we don't really work with anyone on ECMO. So this was kind of a cool thing that we did in Williamsport. So here's some pictures. The far left is the endotracheal tube. The middle and the top is the tracheostomy site. The far right is what a PEG tube looks like. The bottom is an NG tube, the nasogastric tube, and then over on the far right in the bottom is the wound vac, what it would look like on his, like the fasciotomy site. So he was pretty sick before we could start working with him for therapy. So just a little update on before we could actually begin therapy. The ECMO site was moved from his right groin to his neck. So we didn't really do a lot with patients when they're on ECMO if it was at their site of their groin, but once it was moved to their neck, we could do a lot more. And just a side note, a perfusionist is a medical professional who works with the ECMO, and we were only allowed to work with the patient on ECMO if the perfusionist was present. The patient had already, he had a tracheostomy done and his PEG tube was placed, and his trach was to a ventilator machine. So he was still not breathing on his own, but he was breathing via the trach to vent system rather than through the endotracheal tube. He had a wound vac. That was because of the fasciotomy. So that was on his right leg, and it was also on his groin because of the ECMO placement. And then he had multiple abdominal drains, multiple IVs. He had a PICC line, which is for like more long-term medication in his arm. He was no longer sedated or paralyzed, so he was awake. He was able to follow simple commands. He was groggy, lethargic, but he was cleared by the critical care team and the cardiothoracic team to work with us for therapy, and they wanted us to sit him at the edge of the bed. So as part of the evaluation, we wanted to find out an occupational profile on him. So this was obtained by the patient because he had a tracheostomy and he didn't have a speaking valve yet. He couldn't talk to us. So we, were able to communicate via head nods. And then we also got a lot of our information from his wife, who I have called Nora for this presentation. So his general health status was inhibiting him from participating in even his basic ADLs, grooming, washing his face, or even getting out of bed. And he wasn't able to participate really in any of his meaningful occupations at this point. We discovered he was a husband, he was a father of 3 children, and he worked as a construction worker. He was interested in playing video games, he played soccer, and he liked attending his children's sporting events. So his environment at this point was his hospital bed. His room had a recliner chair with a removable armrest. And the hospital personnel were around, the nurses, the therapy team, his medical doctors. And then he also was limited by ICU lines, tubes, and drains. We talked about he was 36, he's male, he's white, he identified as Christian, he came from a middle-class upbringing, and he had a high school education. So we discovered through talking to him and his wife that he had always been very independent. He did not enjoy receiving help from anyone. He's always been very handy, very active. So being stuck in an ICU bed for weeks was not where he wanted to be. We definitely felt that he was getting depressed over his current situation. He was extremely weak. His arms and legs were all very weak, and he had decreased sensation in his right leg from the fasciotomy. And he actually developed foot drop in that leg too. He had poor trunk control with his abdominal wound, and his cardiovascular and his pulmonary systems were very weakened, in addition to his muscle weakness. So we discovered his goals were to become independent with his ADLs again. And at this point, he was requiring complete assistance with all of his ADLs. His quality of life was impaired due to his inability to participate in his ADLs and transfers. And he was also limited by the fact that he was attached to so many lines. It was hard for him to move without an IV pole beeping at him. And then just in general, he was also very, very weak, like profoundly weak. So when you start the evaluation, we obtained, basic demographic information from him and his wife. So we discovered he lives with his wife and his 3 children in a 2-story home. He had a step to enter the house, no railing at the entrance to the house. He had a half bathroom on the first floor, And his full bedroom and bathroom were on the second floor, but he had a full flight of stairs he needed to be able to do in order to get up there. He did have a walk-in shower and a tub shower combo available, but he didn't have any grab bars, no raised toilet seat. He didn't have a walker, cane, or any kind of medical equipment because he'd never needed it before. So for the OT evaluation, I discovered that his arms and legs were very weak. He had less than half range actively, but his passive range of motion was within functional limits. His strength testing on that initial eval, his strength was only a 1 to a 2 minus out of 5. He was very, very weak. And he was dependent with all of his bed mobility. He was dependent for sitting balance. Because of everything that he was attached to, that very first time we sat him up, there was an OT, PT, a respiratory therapist there to monitor his trach and his vent. There was a nurse and a nurse practitioner present, which that really never happened, that we had a nurse practitioner for our eval. And then also the perfusionist was there as well, because they always were present when they were on ECMO for our therapy sessions. And we also had a therapy aide. So there were a lot of people in this room. It was, he'd been in the ICU for a couple of weeks, and it was very exciting that we were starting to work with him. But we wanted to make sure that, if anything happened, that he was protected as best as we could. So when we sat him up, his blood pressure did not handle it well. He got, very dizzy. It had been the first time he'd sat up in a long time. His blood pressure dropped to the 80s, over 40s, and his oxygen saturation dropped down to 88%. So we had to return him to supine, and, the team addressed his oxygen needs, and his vital signs, returned to normal after he adjusted a little. So then it was time to plan our intervention, and he had a lot of barriers. His vital signs were not very stable with an attempt on eval sitting edge of bed. So the initial plan was just to work on arm muscle strengthening, active assist range of motion exercises, which, I could do with the patient, and also teach his wife how to do. Participate in basic ADLs from bed level, like washing his face, oral hygiene, and then work towards slightly elevating his head of bed, and progress to eventually sitting at the edge of bed again. Our plan was to work on improving his sitting balance, participating in bed to chair transfer. Like I said, we had that chair with the removable arm rest, so we could either do a lateral scoot or a sliding board if he wasn't able to, participate in a stand pivot for a while. We wanted to increase his participation in ADLs from a seated position in the chair versus the edge of bed, get him participating in some upper body dressing, upper body bathing, and then progress to bedside commode transfer, and eventually initiate standing tolerance, progressing to taking steps. And that all ended up happening very beautifully for him. So some of the psychosocial aspects, he was very depressed, and he did not handle being in the ICU and being limited to 2 visitors. It was during COVID times, so we weren't allowed to have any children under 18 weren't permitted in the hospital, and they were only allowed 2 adult visitors. And so it was really challenging for him not to be able to see his kids, to see a lot of his family. I think his wife and his mom were the only 2 visitors that he had coming in. He really, really enjoyed working with therapy. He had a good sense of humor, and I think that working with PT and OT was kind of like the highlight of his day, because he just wanted to improve his strength, and he wanted to get better, and he wanted to move and get out of bed. So he really did like working with us. But yeah, he was sometimes mean to the nurses, and definitely had times where he was pretty angry, which we felt sorry for him because he was just so active and independent before all this had happened. The initial discharge recommendation for him was to go to LTAC, which is a long-term acute care hospital. They can accommodate patients with trachs and vents, and just very critically ill patients with lengthy rehab needs. But once he started to progress with therapy, he was, his activity tolerance was getting better, his strength was improving. And then we changed our discharge recommendation to inpatient rehab for 3 hours a day, PT, OT, and speech. And the goal was to discharge home with his wife and his kids, which ultimately did happen, which was great to see. So I know that I zoomed through that. So I'm open for lots of questions about him.
Can you talk a little bit about, you said he was showed a little anger towards the nurses. Can you talk about what that was like?
Yeah, I think that part of it is we come from a different, uh, like nursing and therapy, we come at it from different angles. So once his strength started to improve, therapy is we want to see what you can do. We want to get you moving on your own. Let's see how much you can do with sitting at the edge of the bed. Can you walk your leg over? Starting to get him to participate in doing some ADLs independently. And nursing, they have a different perspective of things. So they come in and they need to get their job done with getting a medication. And as far as like bathing, OT is like, let's have you participate and do as much as you can as possible. Whereas the nurses and the nurses aides would come in and they would just like do everything for him. And so I think that some of it, as well as just being upset that he was in that situation in the first place, he wanted to be doing things for himself. So he didn't appreciate the nurse coming in and just, stripping his hospital gown off of him, or, trying to get him washed up and do things like that, where he wanted to be participating in it more. And as his strength was improving, he was actually starting to be able to do a lot more for himself. And I think some of it was the nurses weren't giving him a chance to do that. So when we worked with him from therapy, he was excited to be able to, I think, participate more. And we taught him how to work around those lines and, how to do some things more independently. And I think he just really appreciated that.
I have a question.
Yeah.
Since he was like in such critical care, can you maybe like explain, like, since a lot of us don't have a lot of like experience outside of peds, maybe like what those, like the progression from like when he was like initially there with like the strengthening and range of motion, how that started, and then how you progress that with like taking it into functional activities within the ICU?
Yeah, that's a great question. So the evaluation was really limited because we sat up at edge of bed and he wasn't able to do much more. So then the next few sessions he started to lose lines. So, he might have had the ECMO site at his neck for maybe my first 2 or 3 sessions with him, and eventually that was decannulated. So he didn't have the ECMO anymore. And then, he lost some of the abdominal drains came off. And so he just kind of slowly, like for, over time started to lose lines. So it started with just sitting edge of bed, doing, passive range of motion exercises with him, active assist range of motion exercises with him, trying to get his arms strengthened. And then as he just got like stronger, his strength started to come back. I wouldn't say quickly, but over the span of 3 weeks, his arm strength was to like a 3+. So he started to progress really quickly with strengthening coming back. And then we would sit edge of bed. We started to do just some basic sitting balance activities with him, holding his hands and rocking forward, backwards, side to side, doing some weight shifting onto his elbow. And then we started to do some, pivots to the chair, which started with, I feel like we skipped the sliding board and we just kind of like did a lateral scoot with him. And then eventually he was able to, bear enough weight through his legs to do like a squat pivot, and then eventually a stand pivot. We started with like handheld assist for the pivots, and then eventually we were able to progress to just, standing with the walker, and that moved to standing with the walker for 10 seconds, standing with the walker for 30 seconds, marching in place with the walker, and then just taking some steps. And actually the day that we went in and he walked like 10 feet, we were just like amazed. So and then he just kind of skyrocketed with his mobility after that. I think he went to rehab pretty shortly after. And I didn't visit a lot of patients down in rehab, but I went to visit him a couple times because, I just worked with him so closely for so long. And to see how much he was like progressing in rehab. I think he was walking like 100 feet with a cane, and I was amazed. And then I actually, with the physical therapist that I worked with, we were walking, I think, to like the pharmacy or something in the hospital, and we actually ran into him and his wife down there, and he was in a wheelchair. He had his TheraBand attached to the wheelchair, and they, we talked to them, and it was just so cool to see him like out. I mean, he wasn't even discharged yet. He was just kind of like permitted off the unit, and to see him like in the community again. I mean, he had lost a lot of muscle tone. He, you know, was very like scrawny compared to like pictures you had seen of him, but it was very cool to see him in the community again. Anybody else?
What other questions do you guys have?
So you said that to get like the occupational profile, you had to talk a lot to his wife, but you relied on like shaking his head yes and no. Have you experienced any other like different ways in the ICU that you've had to like try to get information if you didn't have like someone who was verbal or somebody with them?
Yeah, so if they weren't able to tell me what their baseline was because they didn't have a family member present, I would call family members to talk to them too. But we also rely on like communication boards, which we had just like a stack of them. They had dry erase markers. But unfortunately for him, like his arms were too weak to be able to use it. But some of our vented patients that we would work with, they had perfectly fine arm movement. So, you know, I could get them to do that, and they could either circle things or they could write things out for me. The other thing is some of the communication boards, I could point at things for them. So like yes or no, or it gives like, are you tired? Are you hungry? Are you in pain? And I could point to things for them, and they could, you know, nod like yes or no for me. So we did have a lot of those communication boards. You can also do simple things like if they can't talk to me, I'd ask them like squeeze my hand once if you're in pain. And I'd find just kind of creative ways to get like a yes or a no from them. Even just like some of my, you know, really ill patients, I'm trying to see if they can follow anything. I'm like, can you blink for me? Like squeeze your eyes, you know, something so that I can see that they're like following, because with the ICU, you're working with a lot of varying levels of how much they are, I guess, like what their cognitive status is. And when they have like a endotracheal tube in or a tracheostomy and they can't verbally tell you those things, you just kind of have to think outside the box on ways to get them to be able to communicate a little bit with me. And if all else fails, I'll call their family.
Can you talk more about like how it was working around his blood pressure, like in the beginning, having to raise his bed like a little bit each way to get it to be tolerable, and like kind of what
Yeah.
type of interventions you did, like working around that?
Yeah, so a lot of times we'll go in and we work with patients in the ICU, and we do blood pressures um, pre-moving them, and then we sit them up, like we'll raise their bed up like 15 degrees, see how they tolerate that, raise their bed up 30 degrees, see how they tolerate that, raise their bed up 45 degrees, see how they tolerate that. And you can do blood pressures with each of those if they're symptomatic. So I think when we started with him, he was probably at like 30 degrees already. So we got like a blood pressure at the start, and it was, I couldn't tell you what it was. It was, you know, normal. And then so he, you know, we got like an idea of how are you feeling? Are you feeling all right? And then as a group, somebody kind of brings his legs off to the side of the bed, somebody's helping with his trunk, and then all those extra people were just there just to manage lines. So we pretty much got a blood pressure right away. In the ICU, we mostly would get a blood pressure when we sat somebody up anyways, but we got his pretty much right away. We saw he wasn't tolerating it very well. And I should mention, I did his strength testing before we sat him up. So I was able to get a gauge on his like arm strength while he was still feeling okay. And then when we sat him up, you know, it was very clear that we needed to lay back down. So we did that. And that was really my evaluation, which it seems like not a lot, but for an ICU patient with all those lines, that's a huge win to get them sitting at the edge of the bed. So when we got his blood pressure, and we realized it was, you know, not safe, we laid him back down. And then some of the recommendations we made to nursing was, let's have his head elevated. Let's try to get him to like 45 degrees, make him tolerate that. Let's maybe try to even get him to 90 degrees. Let's see if he tolerates that before we like even come in for therapy next time. So we would try to make sure that he was tolerating that head of bed elevated before we worked with him again. And then just as he was we might not have even seen him the next day. I think it was probably 2 days later that we worked with him again, and he was just kind of medically just doing better and better and better each day. So as his medical status got better, we were able to progress and do more. And eventually he was weaned off of the ventilator altogether. So he was still on the trach for oxygen, but it was attached to a different kind of oxygen machine. So he wasn't even relying on the ventilator for full breathing support at that point. And I think he was just on the vent for nighttime. Yeah, as he was able to just medically get better, we were able to do a lot more with him, but just continuing to monitor his vital signs with pretty much everything we did. In the ICU, they're constantly on a heart monitor, so we can see their heart rate the entire time. Most of the time, they have a sticker on their finger so we can see their oxygen saturation the whole time. The only problem with that is those stickers can be kind of finicky. So when you're mobilizing somebody, you don't always get an accurate read. So you have to kind of learn what the waveforms are supposed to look like, and you can tell if it's an accurate reading or not. But the blood pressure, we just kind of would take it as if he seemed like he was symptomatic of dizzy or lightheaded or anything.
Those are good questions. Any more?
I know you said in the beginning that you had a ton of people in the room with you. Towards the end of him being with you, did it end up being like just you in there with him, or did you still have a pretty big team?
Yeah, so when he had the ECMO coming out, and that's I don't know if you guys can picture what this line is. It's this big line that's coming out of his neck, and it actually like wrapped around his head. So the perfusionist had to be there like managing that. And that was attached to that big machine. So everything that we did was very reliant on making sure that ECMO line was safe. So as long as he had that ECMO, which I think we worked with him 3 times with the ECMO, that whole team was pretty much there. And then as he lost the ECMO, the perfusionist didn't need to be there. The nurse practitioner might not have been there for the next few times. That was pretty rare that we actually had a nurse practitioner in the room for our session. And then it pretty much progressed to just being myself, the PT, and our therapy aide, because he was pretty much medically safe enough that we didn't feel like we needed like the respiratory therapist to be there. Every once in a while, the nurse might be popping in and out of the room, but for the most part, we were able to manage him, just the 3 of us. And then as his mobility got better, he kind of progressed quickly from like being like a moderate assist of 2 helpers to a min assist of 1. And once he wasn't needing 2 people to help, it might have just been me and the therapy aide, and then some of our sessions were just me. It was also pretty rare for an ICU patient to be with me for so long in the ICU. A lot of times they would be there for a couple of days and then they would like go down to our step down unit. But for somebody so critically ill like him, he stayed in the ICU pretty much his entire hospital stay until he went to rehab. So for me to get to work with him for so long was also a cool thing, because that didn't happen all the time. I mean, we did have patients who stayed in the ICU for longer periods of time, and I'd get to really see their progress, but he was with us for several weeks. So by the time that he was ready to go to rehab, his sessions were just myself and him, and then he would walk with PT separately.
Do you like having like such short stays with patients? Like, do you feel like you can really build that connection and rapport with them in just a few days?
I think that it depends on the patient. Some of them you can build rapport with very quickly and very easily. And I think with working in the ICU so much and becoming so comfortable with those lines, and they see how you manage the lines, and they see that you know what you're doing, they learn to trust you pretty quickly. I would say it is hard because you don't see the progress that you would see if you're working with somebody like an inpatient rehab. So like my first job was in inpatient rehab, and I loved getting to see them progress and seeing them go home. So a lot of my patients, I would send them from the ICU to either rehab or a nursing home. And so I didn't really get to see like where they ended up. So I don't necessarily love that part of it, because I do like to see how they, end up seeing this patient in the pharmacy and seeing that he was thriving in the community setting was a really cool thing for me. So I guess that's a hard question to answer because I don't like that I don't see the end goal, but I also really love being a part of the early mobility. I think that's a really rewarding thing. Like I get to help the patient up to the chair for the first time a lot of times, and seeing the family's like relief when they're like, oh wow, he's in the chair. Like that's a cool moment too. So there's things I like about it and there's things that I don't like about it.
Can you kind of talk more about like the discharge process, like with Michael specifically, or even just with patients in general, of kind of like the stuff you look for in order to like discharge to inpatient or even a different setting?
Yeah, so basically the recommendation is either going to be LTAC, which is the long-term acute care hospital. So that's for someone who's very critically ill, still on a vent or trach, and doesn't have a lot of activity tolerance, and you can tell they're going to have like a lengthy rehab need. So that's somebody I'd recommend LTAC for. And then inpatient rehab, they need to be able to tolerate 3 hours of therapy a day. So I'm looking at their diagnosis first, like a stroke. A patient who had a stroke is a great inpatient rehab candidate usually. A patient who's had like an amputation of their leg. Just you get to learn like what the inpatient rehab diagnoses kind of are, and then you look at like activity tolerance. So if I'm working with a patient, I'm like, there's no way that they could tolerate 3 hours of therapy a day, even with lots of rest breaks, then they're probably not an inpatient rehab candidate. So I look at their diagnosis and then their activity tolerance are a big thing. So then I'm kind of like, okay, can the patient go home or do they need rehab for, other reasons? Well, if they can't go home and they're not an inpatient rehab candidate, they probably need like a subacute, like a nursing home level of rehab. So that would be somebody who comes into the hospital with like a CHF exacerbation or a COPD exacerbation. They live alone. They don't have anybody that can help them at home. Their activity tolerance is terrible. They can't get their socks or shoes on by themselves. They won't be able to tolerate inpatient rehab. And then they probably need like that subacute nursing home type of placement. And then as far as home, do they have support at home? What's their house setup? Like Mike's house was a 2-story house and his bedroom and bathroom were on the second floor. Like he's probably not going to be able to go home to that right away. So inpatient rehab definitely made more sense for him. But like, what does their home setup like? Is their bathroom on the first floor? Do they have a first floor setup? Like say that they sleep upstairs normally, but they could stay downstairs in the guest room and they do have a full bathroom downstairs and they only have a step to get inside, or do they have 17 steps to get inside their house? Because some people's houses do have that. So you're looking at those environmental barriers and what kind of support they have at home. If it's a 96-year-old lady who's been living at home independently, and I just I look at her and I'm like, man, there's no way that you'd be able to do your own cooking and cleaning, so if you don't have somebody that can come in and help you with those things, then you probably need to be placed somewhere. So there's a lot of factors. A lot of it goes with like their home setup, how much assistance they have. I'm recommending like home health for somebody, home with home health for somebody who has a spouse or somebody that can be there 24/7 with them. And they maybe only require like contact guard or supervision to get around, then well, yeah, they probably could go home. But you're also making recommendations for like a shower chair and a walker, and you make sure that they have like the equipment that they need if you're going to recommend home for them. So there's a lot that goes into it, and I feel like after just doing it for so long, you kind of can look at the patient and there's no way they're going to be able to go home right now, or yeah, maybe they could go home right now. And if I'm on the fence, I'm usually pretty conservative, so I'll recommend placement for them if I'm really just not sure. I'll if I think I'd lose sleep over it at night or something, I would definitely recommend placement for them. So lots of things that go into that.
And that definitely gets easier as you learn to look at all those factors, and you're able to just kind of compare situations also. It can be helpful.
Yes. Yeah, I think comparing situations is also a key point. You look at, and also just having rehab experience too, it was helpful going to acute care because I had worked in patient rehab. And so I was like evaluating someone. I'm like, oh, well, there's no way they could tolerate what I just did for the past year and a half, or, maybe they could tolerate that. So it's nice to have just some of it comes with experience and you kind of learn who can tolerate what.
Those are all very good questions. Any others? Nicole, did you have any unexpected challenges working with this case that you didn't foresee when you were looking at the admission information?
I don't know. I feel like nothing really surprises me anymore. I just kind of go into every evaluation like not knowing what I'm, walking into. So I can't think of anything specific for him.
Yeah, and we've talked about like in labs, you read the information and you kind of get a picture, but you're never really sure. So just being kind of open and ready, just having some things in mind as a plan, but being open to adapting your plan as you need.
Yeah. I think that in general, I go in with a plan of, that's with every patient I work with. I go in with a plan of, I want to try to see bed mobility, a transfer to the chair. Can they walk to the bathroom? Can I see a toilet transfer? Can I see them, get dressed at all? Can they participate in oh, my dog's here. Can they participate in putting a gown on or putting socks on? And you just go into it with an expectation of I want to see as much as I can of those things, and you just take what you can get. But for him, sitting up at the edge of the bed was all we got, and that's and strength testing, and that's okay. I tested his cognition. I was able to assess his vision. Is he tracking? Is he scanning? Is he following simple commands? So there's more to it than just sitting edge of bed. But as far as mobility, you just take what you can get. I go into it with a plan, and plan happens sometimes. You have to be very flexible working in acute care.
Yeah, and there's always a lot of good information you can get from what you do see. Even if it's, you didn't get through a whole bunch of things.
Yes.
You can, like Nicole said, get cognition information, vision, even just, looking at things like fine motor and just activity tolerance, just you can tease out a lot from just a few things that you do get to see. Okay.
Yep.
Any other questions from the group? Okay, I think that's it. Well, thank you, Nicole. Thank you for your time.
Okay.
That's a great
You're
presentation.
welcome.
Very interesting case.
Cool. Well, thank you. It was nice to share it with you guys. Good luck with everything.
Thank
Thank
you.
you.
Yeah.
Thank you.